G'day. Welcome everyone once again. It has been a couple of weeks, but we're through. We have had Christmas, we have had New Year's. My name is Kane Treble. I'm a GP based out of Mildura, far northwest Victoria, and I'm here to make sure we can get you through the 2025.1 KFP exam. And I'm just going to go back to the chat here. Demir was studying through for the CCE exam and has passed, so a massive congratulations. Very well done. For everyone who's been watching the channel as well and has seen his effort, his progress, his persistence in turning up for each week and putting in that hard work, it has paid off, and a massive congratulations. So I hope you are doing something nice to celebrate. I mean, I'm sure you've already celebrated once exam results are out, but you should have another celebration every single week until the end of time as far as I'm concerned, because mate, what an effort. And again, all that hard work you put into it does pay off. Of course, we're all here to put in some hard effort as well, because we are 10 days before the 2025.1 KFP exam. We are in that final crunch period, and there is still plenty of opportunities to improve your technique, practice as many questions as possible, and make sure that you have the best chance of getting through the KFP exam. This is, of course, the last time the RACGP, for now at least, will be running the exam in this format before moving across to a more multiple choice style format. I think that there's pros and cons each way, and we have plenty of cases, or three cases prepared tonight to run through and give you some tips and tricks as to how to get through this existing format here. Now, of course, we do have some final tips for you to run through, and really the number one thing is to remember, read the case thoroughly. This is an exam that's about nuance, about understanding the case or the patient that's been put in front of you in the context that they're describing. So focus on that patient history, the examination findings, and the context of the patient, because that can have dramatic implications in how you answer that question. Try and avoid skipping or glossing over key information. I know it's easy to sometimes put patients into pigeonholes, and this is an exam that you will miss marks and you'll be caught out on different things if you do that. Make sure your answers are relevant to the scenario. Again, sometimes if you're repeating enough practice questions, you'll notice common themes amongst them, and it's easy to kind of fall into the trap of saying, oh yeah, this is a older patient, so we'll refer to geriatrician, but it may be they're actually just under the age thresholds for that in some regards, or let's say one of the default answers for a question might be referred to a pediatrician and it's a geriatric patient. Extreme example, but you really need to make sure that each thing is actually relevant to the case that's put in front of you and their context. So pay attention to the evolving information in the case as well. Often there'll be a stem that's provided, and as the questions progress, as the case progresses, additional information is planted. Pay close attention to that, because they are giving that to you for a reason. They are trying to tease out additional bits of information, and so again, does that change your answers? Does that change the context of the question? It should. And you should be reflecting that in the answers that you provide. So when it comes to actually answering, make sure that you provide detailed and precise answers. Try and give the sides of the patient, if it's a right arm or left arm, if this is acute, if this is subacute, if this is chronic. Really spell it out. And I know at times it feels like you're saying, well, of course they're going to know that. Yeah, maybe. You need to prove that you know that too, and the only way to do that is to state it in your responses. With that as well, try and avoid vague terms like healthy eating. Try and specify, meal plans, calorie counts to reach specific kind of food products to be eating or avoiding. And stick to the number of answers requested. This is a really easy trap to do. I've done it myself on the exam day when you're rushing through, trying to get through as many answers as possible. Make sure you underline, circle, have some way of flagging to yourself how many answers they've asked for and how many answers you've given. And tied into that one as well, really, because it is a form of overcoding, but try not to overcode with unnecessary information. If you find yourself using if, and, or, but, or commas, those kinds of things, you're probably joining answers, in which case that's going to fall into overcoding territory, and you will not only not get the marks for the additional information you've put there, you will lose marks. They will subtract marks from your exam, which will have an obvious massive detriment to your overall performance. Now, make sure as well that you're using up-to-date clinical guidelines. So make sure you're only using the latest ones. Try and avoid anything that's more than a couple of years old. And really ask yourself, is this practice outdated? Is this something that used to be done that I probably need to just refresh myself on and make sure this is still the way it's done now? Because it's incredible how quickly information changes. This is also something where make sure you're familiar with the latest standards. So if you're using things, pardon me, like coughing into a microphone, if you're using things like Heart Foundation guidelines, make sure you're on the latest version. If you're using COPDX, make sure you're in the latest version. Try and track down. And a really important thing is usually at the beginning of each of these kinds of documents, you'll find a summary of changes. So it's a really handy way to just quickly refresh yourself on what may have been different from the last release, in which case that may change the responses you give. And again, make sure the guidelines are contextually relevant to the case. Now, time management is critical for such a long and busy examination. So one of the things I try and do in here is to allocate you around 2 minutes per question, because that's roughly how long you want to be spending in the exam to make sure you also have a bit of time left over to go through and flesh things out or fill in things that you may have skipped over. And so if you're finding that you're lingering, if you're spending too long on one question, it might be worth finding a way to flag that and try and come back to it later. But really important is that you do complete all questions. Even if you don't think the answer is correct, you don't lose marks for incorrect answers. You might get 0 if you do something dangerous, so don't do something dangerous. But try and make sure you at least get something down, or the number of responses per question, to just try and maximize the chance of getting those answers in. It's incredible how even a few extra points can make or break your exam results. And of course, make sure you're keeping an eye on the clock all the way through to make sure you're actually hitting your kind of time targets as you go along, to make sure you're not going to run out of time at the end. Really handy, and the RACGP releases reports every single year of the KFP exam breakdown. I know it's a bit tedious, but it's actually really valuable to read through and kind of see, well, what were the things that actually caught people up? What were the traps they fell into? And it's incredible, you see the same things appear again and again. And so that should be good little reminders to yourself not to make those same mistakes. See if it's something you find yourself slipping into, in which case, spend a bit of time, spend a bit of effort in these last 10 days in perfecting your performance in that particular niche. Really important is to avoid missing those contraindications in treatment plans. Often there'll be an allergy that's kind of snuck in, maybe a bit more subtle, or there might be a comorbidity that precludes treatment with a particular medication or particular non-pharmacological management strategy, and you have to tie that into your answer, because while again it might be a pigeonhole, this patient I do this, it may not apply in the context of that patient. And again, then try and consider those social and cultural factors in the patient care. This is particularly relevant when you're looking at patients who may live in a rural setting, in regards to accessing additional services that may not be readily available. You may have to think a little bit more on your feet on what you would do in that situation if you were a bit more limited with resources. And so again, focus on managing those medical and non-medical issues. If they're giving you social information in the STEM, it's probably relevant, and you should be acknowledging that in some way in at least one of your answers. Of course, you might just be here for some practice questions tonight. We have 3 cases, each with 3 questions prepared, and as we do every single time, I think we'll get 2 minutes on the clock, and your time starts now. All right, so here we have a not uncommon problem, unfortunately. And so let's have a look at some answers here. Now, important to remember with diabetic foot ulcers, the situation can turn pretty toey pretty quick. It's usually not the patient's sole problem, but with good medical care, the wounds can heal. And if you thought I wrote this question just to make those puns, you would be able to 100% correct, and I couldn't help myself. So what are the most important risk factors to monitor for the formation of a diabetic foot ulcer? Who are those patients you need to pay extra close attention to? Tongue twisters. Patients with peripheral neuropathy and peripheral vascular disease are by far the most sensitive predictors for who's at risk of developing diabetic foot ulcers. Tied into that as well, often trauma does contribute to that, but it's definitely not as big a risk factor in terms of who to monitor, who to watch out for. So for this question here, the neuropathy and the vascular disease is going to be the bigger marks. If you do mention trauma, yep, you might get something, but it does reflect that you may not have quite the same polish or understanding of those risks. This is of course taken from the Diabetic Foot Ulcer article from RACGP. Actually a pretty good read if it is something you're not too familiar with, to just get a good overview of patients at risk, what to be screening for, how to manage these patients, and what to do next. Could that be potentially relevant to the rest of this case? Let's find out. Let's get another 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some answers here. This is a question that I think might catch a few people, and this is one of those situations where being up to date with guidelines is particularly valuable. So until relatively recently, I think most people were using Augmentin for these kinds of wounds, but the guidelines have changed, and now dicloxacillin or flucloxacillin, I think most people will probably be more readily familiar with the flucloxacillin, is considered to be first-line antibiotic choice for James. And I've intentionally not listed any allergies here. It is one where I think if they did specify an allergy, you might argue one way or another. But without that, they could consider accepting cefalexin, but probably with less marks involved, given it's more if you have a immediate sensitivity to penicillins, that's when that would be more indicated. So, hopefully that didn't catch out too many. For those who aren't familiar with dicloxacillin, flucloxacillin can cause renal impairment, liver impairment or deranged liver function. So if you do have someone who is a little bit more on the liver side, or history of cirrhosis, things like that, dicloxacillin may be a safer option for them, but it can cause renal impairment. So it's kind of pick which organ we want to hit. Food for thought. Of course, we have another question up for this case here, so let's put 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some answers here. And boy, is this one a bit of a doozy. So a hypoglycemic episode where they're requiring assistance instantly takes it up to a more serious hypoglycemic event. And so if you go to the national standards for driving, forgotten what they're called, the fitness to drive standards, that's the one, there we go. They actually specify that the patient should not drive for a minimum period, which is recommended to be minimum of 6 weeks. And wow, is that a long time? But the rationale for that is that it often takes quite a long time, many weeks, for the patterns of glucose control and behavior to be re-established for any of these temporary impaired hypoglycemic awareness kind of events to actually resolve. So 6 weeks no driving. So of course, the next part here is James should not drive. You're going to get less marks if you're just saying that without specifying that time period. And tied into that, but is actually a separate response and would get extra marks as well, as James should not drive until he has been cleared to drive by a medical professional. So it's actually tying into that not only can he not drive, he needs to actually be seeing someone as well for that to happen. Now, the questions come up in the chat. Does this have to be a specialist? Not necessarily. In fact, it just says a medical professional. And this is also reflecting that many GPs have the expertise and experience in being able to identify those who are going to be safe driving again versus those who are not. Now, of course, James should take appropriate precautions when to help avoid these kinds of events happening again. And I think as long as you're putting some kind of example in this category, you're going to get those marks there. So whether it's complying with the general medical review or requirements, not driving, if his blood glucose is less than 5, or while wearing a continuous or flash glucose monitor, if the predicted glucose level is showing a downward trend towards the hypoglycemic range. Those are those things to be monitoring for and ways to kind of work out precautions in place to prevent these sudden hypo episodes from occurring. Tied into this as well is then the more kind of prophylactic measures. So don't drive for more than 2 hours without considering having a snack or some kind of oral intake. He should avoid delaying or missing meals, particularly a main meal. And James should make sure he has adequate glucose in the vehicle for self-treatment if needed. And finally, if he feels he is having a hypoglycemic episode, he should safely steer the vehicle to the side of the road before turning off the engine and removing the keys from the ignition. Long-winded, very long-winded. And I think some people would be a bit hesitant are we including too many steps here? Is this veering into overcoding? I think you could argue either way. Admittedly, it's probably the more risky response on here, which is also why I've placed it lower. But it's important to not only veer to the side of the road, but the removing the keys from the ignition means that if he does become less conscious or more confused, it's that extra barrier to actually restarting the car and potentially getting into an accident. And again, all of this is taken directly from the fitness to drive standards, which is why I think that would be used for the answer matrix for questions like this. Oof, we all good? We might all need a snack and a catch up and a break after this one. But we do have another case prepared. Let's crack on, shall we? Let's get 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some answers. This is one of those cases where you probably notice sometimes you get waves of things. Lately, I've had a wave of palliative care patients, so I thought I'd throw this one in here as well. What anticipatory orders are appropriate for managing evident symptoms in palliative care? Write 3 specific medications, route and rationale. Doses are not required. The main medications we tend to use in palliative care is subcutaneous morphine for pain, subcutaneous midazolam for agitation, subcutaneous metoclopramide for nausea. You can use oral ondansetron as well, or IM ondansetron in this kind of setting, or there are wafers as well, but in this kind of setting where she's not really eating much, most people I think would probably stick to metoclopramide. And you can do, as required, subcutaneous glycopyrrolate or hyoscine for respiratory secretions should things progress. I'm really not a fan of glycopyrrolate or hyoscine for secretions, but I'll go on a rant for another day. We have from the chat here, change Targin to subcut morphine, and I think that the specifying ceasing Targin would actually count for a mark here as well. So definitely would get marks from there. Changing to morphine 60 milligrams per day via Nicky pump. So I think certainly that's probably an appropriate dose for someone who's already on an equivalent of 40 of Targin over 24 hours. I don't think you'd risk narking them on that one. That's a dose I think I would be pretty happy with prescribing as well. As needed on Dan's sublingual, yes, you could try it. I think though, because they've specified that there are some troubles with oral intake, I'd probably prefer a subcutaneous route. I think you would probably get 1 mark for that still though. As needed, olanzapine, 2.5 milligrams subcut. Olanzapine actually tends to be a little bit less commonly used. Midazolam is usually favoured by most areas, and to be perfectly honest, not entirely sure why. I think olanzapine can be used, and I think you would still get some marks for that as well. Now I'm going to mention a couple of things here, and I said I wasn't going to go on a rant today, but bugger it, I will. So the subcut 4-hourly. This often comes back to your experience, the nurses who are involved experience, the setting of the venue. For a lot of my palliative patients, I actually don't put time locks on it. So it's essentially titrate to effect and to the patient's conscious state and level of sedation. And that just gives them that flexibility that if they've given a dose of something and the patient's still in a lot of pain, they're not forced to wait that 1 hour or 4 hours or whatever time is specified. They can just give that extra dose. And particularly when you're starting these orders, that can be really, really helpful to work out if you're just using initially PRNs or as required orders. It lets you work out then, well, where do I start that Nicky pump? And so for here where we're kind of starting medications, often I would actually leave the Targin in place, start these subcut orders, and after 24 hours, go back and actually work out what were their requirements for that period, and I would use that to then start the pump to work it out. In this case specifically though, where they've said she's not really tolerating oral intake, that's where I think Demi's suggestion of starting the Nicky pump now is actually pretty sensible, and so I think specifying that as well, yeah, you'd get the marks. As for the glycopyrrolate and hyoscine, I'm getting up on my box. It's a horrible medication, or a horrible class medication for palliative patients. For those who've heard the death rattle, the secretions in the back of the throat, it's something that can be quite distressing for family, for care providers, but not for the patient. The patient's deeply unconscious, and the whole reason why they're getting those is that they're no longer swallowing, they're no longer clearing those secretions, and so as they're breathing, you get that little gurgle there. I tell friends and family and care providers, that's great. It sounds really yucky, doesn't it? But that's actually a really nice sound, because that tells me that we have that person very comfortable. They're so comfortable, they're so at peace that they're not bothering to even swallow as much as they would normally do. So I think that's a good sign we're on top of their pain. Yeah, we've got some medications we can use to try and dry it up that might make it sound nicer. If you've ever been out on the town, hypothetically, had a few too many drinks maybe, and have fallen asleep with your mouth open, you wake up, you've got that really dry mouth, that dry as a bone mouth. It's a pretty unpleasant sensation. And that's what we induce in these patients to try and control that sound, control those secretions. And so in some regards, we're actually making the patient more uncomfortable to make ourselves not have to listen to it. And sometimes just that explanation, that bit of discussion around is enough to make people a bit more comfortable and happy to maybe hold off on using those kinds of medications. Not always though, and so it can be handy to have them there, but often just that bit of a discussion around, look, if we're really focusing on their comfort, that's probably not something we need to be as worried about. It's that education around why that gurgle is there. Okay, I'll get off my box now. And we have a comment in from chat here. Some nurses get the shits if I don't put in strict time guidelines. Yes, some nurses do. They are incorrect. You do not have to specify timelines. And if they do, I actually write no time lock. That kind of puts the comfort into them, because what they're worried about is if you don't specify something and they're seen to be giving it too frequently, they wonder, well, am I liable if something goes wrong? Whereas I can say, well, no, I've taken that liability myself. I've specified no time lock. You're in the clear. You don't have to worry medico-legally. I will wear that. And that's why I mentioned as well that you do have to kind of judge with the patient, with the facility, with the staff, kind of their level of comfort as well, their level of experience. Are they likely to do something silly? In which case I might be more inclined to specify some locks there. But for the teams I've worked with for a long time now, for years now, I'm very happy to say, as required, no time locks, and we can titrate to effect a bit more rapidly, a bit more readily, and get that patient more comfortable sooner. There we go. That was a good little chat there. Of course, this is 2.1. We've got more questions in here, so let's have a look. Let's get another 2 minutes on the clock, and your time starts now. All right, time is up, and let's have a look at some answers here. So hopefully not a situation you find yourself in, but these kinds of things do happen, unfortunately, falls in particular, and you'll sometimes find that one of the answers for these questions is hidden into the stem as well. So sure enough, if we look at this list here, we do have death occurring within 24 hours of a fall in an aged care facility. The first thing I'll point out with these is that each state and territory has its own little laws, but there are some commonalities between them all, which is what's been used to put this question here together. So of course the number one thing is going to be a death resulting from an accident or injury, so an unexpected death. A death occurring in unexpected or suspicious circumstances. If we can't explain it, if something feels a bit off, going to need to go to the coroner. And of course, death where medical care or treatment may have contributed to the outcome. You'll sometimes hear in some states there might be kind of time locks on there as to when that's considered to be the case, whereas other states will have rules which is more regardless of when the operation or procedure occurred, if it actually contributed to the death, it still becomes a reportable death. Coming in from the chat is pregnancy. So yes, in some states and territories, all pregnancies are considered to be reportable. Recent fall, again, the time frame will change depending on where you are. Recent general anaesthetic, again, depending on procedure, and cause of death suspicious. So all fantastic responses in there. Good. So in this case, I hate to say, but yes, this would be a reportable death to the coroner and would need to be discussed with them. For places like Mildura, where I am, we're 6.5, 7 hours drive to Melbourne. So often they fly bodies down, and more often than not, they just get a CT scan and are sent back after 24 hours. So it's a lot of legwork. We appreciate it doesn't tend to change management of patients so much, but it's a way of trying to track, say, facilities. If there's a sudden run of falls occurring or suspicious deaths, are there things we can actually use to try and improve the situation and prevent these from occurring again? So a pretty important one to try and track and trace. All right, we have a third part of this question, so let's get 2 minutes on the clock again, and your time starts now. All right, time is up. Let's have a look at some answers here. So the clinical criteria are going to be no palpable carotid pulse, no heart sounds heard for 2 minutes, no breath sounds heard for 2 minutes, fixed, non-responsive and dilated pupils, no response to centralized stimulus. Some examples of that would be trapezius muscle squeeze, supraorbital pressure, mandibular pressure, or the sternal rub. Although do be mindful, if you're doing a sternal rub, just make sure you don't cause any skin tears, particularly if they're old and frail. No motor response or facial grimace to painful stimulus. I would be a bit nervous using an or there. I'd just stick to no motor response to painful stimulus, or no facial grimace to painful stimulus. And that's, again, response like pinching the inner aspect of the elbow or ear, just something to cause a bit of pain there. And interestingly, one that catches a lot of people out is ECG strip shows no rhythm is actually not worth any marks. It's considered an optional part of the assessment, but isn't one of the ones that's required for verification of death. Coming in from the chat, we've got the absent papillary light response, fantastic. No response to sternal rub, no breathing sounds for 10 seconds, 2 minutes. So a bit longer there, absent carotid pulse for 10 seconds, 2 minutes, no response to voice. So that would be, you would, I guess, class that as a centralized stimulus, I guess, if you're right up in their face maybe. But yes, so legally, we should actually be doing that auscultation for a full 2 minutes. And I can tell you, it's a long 2 minutes, particularly if the family are there and watching you do it all, and you feel a bit stupid because everyone can see that the person has passed away. But them's the rules. Now, there have been some unfortunate and embarrassing cases where people have been declared dead and they're not. And so I think it is important to actually do it for a good length of time to just make sure you're not going to find yourself in one of those situations. Now, I will admit that there have been times where I might be, say, in a funeral parlour where I'm happier to perhaps be a bit more brief with the verification because it tends to be a little bit more obvious. But again, if we're doing things to the letter of the law and if we're asked in an exam, and yes, this is fair game, these are the things you need to be popping in there. Again, as an aside, I'm doing a few of these tonight. The verification of death is not a consultation that you can actually bill through to Medicare, and this is a point of contention for some people, but I kind of see it as my final service to that patient, looking after them in their medical needs. It's that final chance to wish them well on whatever journey they're on next if you're into any of those kinds of things. But I think it's a nice way to kind of tie up that patient-GP relationship, and you do it for the love of the job, really. You don't get paid for it, but that's the way it goes. All right, so we do have a third case prepared for you tonight. Thank you for staying up so late on a Wednesday night. I'm sure there's other places you would prefer to be. 10 more days you'll be through this exam, so just hang in there for that little bit longer. Let's get 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some answers. And this is rosacea. This is something that is a little bit more common in pregnancy, or pregnancy can flare it up, particularly if you're known to have it already. But you will occasionally see someone that this is the first time they've ever had it, and sure enough, pregnancy is one of the risk factors for it. Of course, the key differentials here is going to be something like acne vulgaris, which is something that can also be flared up by pregnancy. I think the distribution can be quite similar. There tends to be more of that comedonal kind of appearance to it, and normally you do still get some response to using over-counters. Of course, the other differential here would be a periorificial dermatitis or plain old eczema. Again, you'd kind of look to the history for those kinds of things. Normally you'd expect to find history of similar things there. And so in this setting, with this distribution, with this rash, it's rosacea. Not very exciting. How about we have a look at the next question then? Let's get 2 minutes on the clock, and your time starts now. right, time is up. Let's have a look at some of the answers here. So, for those who do have a bit of a derm interest, this question should be right up your alley. There is so much we can do that's not just through tablets or gels or creams of people, although part of this, I guess, would be beneficial for it, but also those non-pharmacological management strategies, and of course encourage Sarah to record a symptom diary to aid the identification of triggers, because it's probably not just the pregnancy that's causing it. Yes, that's going to nudge it along, but there's a lot of other things that are going to be triggers for rosacea. So some of those common triggers are, and the things you would just tell her, look, just avoid these off the bat. Spicy foods, hot cold temperatures, so people that like really hot baths or really hot showers, just try and make it a little bit cooler. Exercise, which really sucks, especially when you're trying to stay fit and active, control your weight during pregnancy. He says like he's ever been pregnant. Sun exposure, so UV radiation can be a trigger for a lot of people. Certain cosmetic products, so you'd be asking if anything's changed, if there's anything new, or if she wants to rotate and try older products or different products than she's using currently. And there's some medications, particularly those that cause vasodilatation, that are known to trigger or flare it, or certainly make it more prominent. Alcohol, thankfully she should be avoiding this during pregnancy, but good to double check. And some fruits and vegetables, which can vary person to person, dairy and marinated meat products. Now, they're going to give you the most marks there, but of course other things are those simple things that we often take for granted. So moisturize frequently, try and condition the skin and get it as healthy and in good condition as possible. Use mild synthetic detergent-based cleansers rather than traditional soaps. Use physical sunscreens, so zinc oxide or titanium oxide. I don't think you'd have to specify, to that level, but using physical sunscreens with an SPF rating of at least 30, and avoid the use of topical steroids, as they often aggravate rosacea. And unfortunately, the often knee-jerk reaction to a rash is to throw some steroids at it, and it will likely flare if it is true rosacea. Another little sneaky trick that I learned from DermNet that I never knew before, but I guess I've never needed to. Cosmetics with a green tint will minimize the appearance of the redness of rosacea. And so for patients that have issues they really can't get control, apparently you turn them a little bit into the Hulk and everything looks a bit better. You live, you learn. That's a new one for me. All right, we have another question on this case. I'm going to cop hell for that one. Another question on this case. Let's get 2 minutes on the clock. Your time starts now. All right, time is up. Let's have a look at some answers here. So the correct answers here are estriol, alpha-fetoprotein, AFP, inhibin A, and of course, beta human chorionic gonadotropin, beta HCG. This is taken directly from RACGP's guidelines for prenatal testing, which you can find in their genomics and general practice section. And this question I've intentionally put in here, so typo on my behalf, I've put in here 3.2. This is indeed question 3.3, sorry. But I've intentionally put this one in here because I want to highlight as well, there's probably going to be questions that you don't know. I did not know this. I had to look it up myself and put in the question together. You may know it. Fantastic if you do. That's actually really impressive. But there's going to be things that are in there almost to trip you up, and sometimes I think they use these to work out who's the super good people that are going to get extra good marks and how to differentiate them from each other. I know from questions I've done in exams previously, I've thought there is no way in hell I would ever have known this, and that's okay. Give it your best. Often these kinds of questions will be multiple choice. Occasionally they are the short answer, in which case just put down what you think is common sense, what you think is appropriate. Don't beat yourself up over it. Really, really important if you come across a question like this where you're just like, I've got no idea. Just give it a go and say, cool, maybe not. Maybe I didn't do fantastic on that question. Let's see how that next question goes. Let's get back to ones that I feel more confident on. So maybe a bit of a mean question, a bit of a harsh question, but just to remind you that they do this from time to time. You're not going to know every single answer to every single question, and that's okay. Just give it your best shot. That's all we can ask for on this exam. Of course, we have a whole other week to go. Well done for getting through this week. I am going to run another live stream on next Wednesday as well before the KFP exam. So if you found these helpful, please jump in. I'd love to see you there. Pop some answers in the chat. Dimi's been fantastic tonight for giving it a go, putting some answers in. And the best way to get feedback to work out what mistakes you might be making is to throw yourself out there and see what you think and get that feedback. Now is the time to get the feedback, not after the exam. Thanks. Of course, the exam format is changing, and so I am contemplating one of the key reasons, if I take this right back, one of the key reasons why I ran these sessions was I did struggle myself to get through originally until I worked out what I was doing wrong, and I didn't want other people to be in that same position. So with the change in format for the exam, I'm not sure if these live streams are going to be needed anymore, but I enjoy doing them, and so I'm tempted to continue doing them. If it's something that you think would be helpful for those that come after in the new format, I'd love to hear your thoughts and your feedback as well. If you think that I could be doing other things as well, let me know. I'm just keen to hang out, do these kinds of things, and we'll see where they go. I still do the CCE sessions as well. They're great fun. And again, I really encourage people to jump in on those because it's as much using the technology, using Zoom in the way they use in the exams. It's good to play around and know what works in your setup and doesn't work in your setup. So the sooner you start practicing online as you would for the exam, the better. All right, that's enough for tonight. We have hit 9:23. Thank you guys so much for joining tonight, jumping in and putting yourself out there. You are more than welcome, Cecily. Great to see you in here again this week. And I hope you all had a wonderful Christmas, New Year's period. Have recharged yourselves, and yeah, we'll keep cracking on. For those sitting next week, I will see you on Wednesday. Best of luck for the exam as well if you don't make it on the Wednesday session. But the fact that you're listening to this says you're putting in effort, you're giving things a go, and so I think you're going to be putting yourself in the best chance possible of getting through. With all that said and done, let's be done. Have a good night, guys, and I'll see you next week.